Hey, welcome everybody to another Fungisphere talk. Today we're having a talk on the theme of therapeutics and global access to pharmaceuticals. It's one of our themes, and that theme is led by Philip Kwok. And I'm pretty excited to hear from his colleague, who's going to be talking to us about inhalational delivery systems, which I think is something we'd like to see in antifungal medications. So Philip, I'll hand over to you to do the proper introductions. Thank you.
Thanks, Justin. So hi, everyone. Today, we are very honored to have Dr. Jenny Lam from the University of Hong Kong to give a talk. So I knew Jenny when I used to work in Hong Kong at the University of Hong Kong back in 2011. And she's an associate professor of the Department of Pharmacology and Pharmacy at the University of Hong Kong. She got her MPharm and PhD degrees from the University of Nottingham, and she's a registered pharmacist both in the UK and Hong Kong. And her specialty is on novel delivery systems for macromolecular therapeutics, including nucleic acids, proteins, and peptides. But she also works on small molecules. So today she will talk about inhaled formulations of an antifungal drug, voriconazole. So Jenny, you can share your screen when you're ready.
Okay, so can you all see my screen?
Yes.
Yeah, thank you. So thank you, Philip, for the very kind introduction. Just to clarify that the image that you've seen is not fungal spores. So these are actually the SEM images of some dry powder particles that we prepare in the lab using different particle engineering techniques. So this is also what I'm going to talk about today, is how to reformulate dry powder of antifungal agents that can be used for pulmonary delivery. Okay, so just a bit background of my research. So as Philip just mentioned, I've been working in the drug delivery field for quite a long time, over 15 years. And my primary interest to start with is to deliver large molecules like nucleic acid, proteins, peptides, antibodies. But I do also work on small molecules, but with a special interest in antimicrobial drugs, which include antiviral drugs, antibacterial, as well as antifungal agents. So we're interested in formulating these therapeutics as an aerosol, especially dry powder aerosols, make it suitable for inhalation and intranasal delivery. So we hope that we can build a platform that had a wide range of clinical applications for the treatment of different lung-related diseases that include infections, as well as asthma or cancer, or use it as a platform for vaccine purpose. So in today's talk, so I will first talk about why we are interested in developing a pulmonary delivery system for the treatment of lung infection, and in particularly why dry powder aerosol as compared with liquid aerosol. I'll briefly introduce two particle engineering techniques that we use in our laboratory to prepare dry powder formulation that include spray drying as well as spray freeze drying. Then I'll talk about one of our ongoing projects on development of inhaled voriconazole, which is an antifungal agent into dry powder form using spray freeze drying technology. And just lastly, I will briefly talk about how we use this platform to develop other inhalable therapeutics for other diseases. So we know that the lung infection has been affecting our life. So not only because of the COVID-19 that happened recently, but also we have been having a problem with infection caused by bacteria or fungus. So in order to treat lung infections, the major treatment is really to find antimicrobial agents that can stop the replication and the transmission of the pathogens from patient to patient. So the major treatment is really to administer antimicrobial agents to the patient. Most of these antimicrobial agents that we are using clinically are either administered through the oral route or the parenteral route. So these are systemic delivery system. Oral route is, of course, is the first choice, obviously, because it is easy to administer. The patient know how to take the medication, and it can be used not only the inpatient, but also the outpatient as well. But we know that not all the drugs can be administered through the oral route. For example, if the drugs are poorly absorbed, or they undergo extensive first-pass metabolism in the liver, or they are not stable in the GI tract, for example, biologics or proteins, then we need to go for a different route of administration. And usually we go for parenteral route, which include IV injection or infusion most of the time for antimicrobial drug. These can guarantee to have a high bioavailability. But the problem with the parenteral route is that you require healthcare specialists to do the administration, and it is invasive, and it really limits to mostly inpatients only and not for outpatients. And for systemic delivery, the other problem is usually these drugs will circulate in the body. So in order to get sufficient amounts of drug in the lung for its antimicrobial effect, we need to give a high dose of this drug. And this will also increase the risk of systemic side effects and toxicities. So if we are going to treat lung infection, then it seems to be the most logical ways to deliver drug directly into the site of infections by the pulmonary route. So pulmonary delivery has been well established for the treatment of diseases like asthma and COPD. So they're non-invasive. So all the patients need to do is to inhale the medication in order to get the drug into the lung. And it can guarantee the drug to get to the site of action directly to have a maximized local drug concentration for the antimicrobial effect. At the same time, you can reduce the dose and reduce the exposure of the drug to the systemic circulation, and thereby reduce the risk of the toxic side effects. So there are a number of ways to deliver drug to the lung, but I'll focus on nebulization and dry powder for inhalation because these are the two ways that can deliver high dose of drug. Because most of the time, antimicrobial agents that we use require high dose in around the range of tens to hundreds of milligrams. So these are the two methods that can deliver high dose of drug. So the first one is nebulization. So nebulization requires the use of the nebulizer in order to generate the liquid aerosol that can be suitable for inhalation. So these are delivery of liquid formulation. And the aerosol size generated by the nebulizer usually within the appropriate range to deposit in the lung. All the patient need to do is to breathe in through the face mask or a mouthpiece. So it doesn't require a high inspiration efforts by the patient. It can deliver high dose of drug, but it can be quite long in terms of the administration time. So if you have a high dose to administer, it may take 20, 30 minutes or even longer to complete the administration procedure. The nebulizer, the disadvantage is that it has to come with a quite bulky machine, which require maintenance and proper cleaning. And the major problem during a pandemic situation like happened recently in COVID-19 is that because the nebulizer generate aerosol and the patient breathe in and breathe out through the mask, and there's a possibility these aerosol will escape from the face mask and then get into the atmosphere and contaminate the surrounding environment, which actually encourage the transmission of the disease. So there has been conflicting recommendations on whether we should use nebulization in clinical settings during pandemic situation. But the bottom line is if the nebulization cannot be avoided, then we have to make sure that there's a proper filter on the equipments to minimize any the escape of the aerosols, and also the healthcare professional working around the patient should wear proper PPE. So another way to deliver high dose of drug into the lung is by dry powder for inhalation. As compared with nebulization, a dry powder inhaler is more portable and easy to operate. And because we are formulating the drug in a solid state, they tend to have a better stability as compared with the liquid formulation, which is particularly important if we are talking about proteins, peptides, or other macromolecules. It can also use for high dose delivery. So if one inspiration is not enough to deliver the dose. The patient always can have separate inspiration in order to get the dose required into the lung. And the major advantage of dry powder for inhalation is that because the inhaler is portable, it's very easy to carry around, it's very convenient, and it is suitable for outpatient use, and it can be self-administered. Okay, but the major issues related to dry powder for inhalation is that it relies on patient inspiration efforts in order to disperse the powder into the powder aerosol, which means that patients cannot have a poor lung function, because if the patient is very sick, they have a compromised lung function, there's a possibility that they may not able to generate enough inspiration efforts to disperse the powder. So if the patient is very sick, then we need to go back to nebulization if we want to get the drug to the lung directly. So there is quite a number of different barriers to overcome in order to get the drug into the lung. First is related to the anatomical and the physiological properties of the lungs. As we all know that the lung is sort of highly branched and there are airway bifurcations, which means that the aerosol, when they cannot really, if they travel in a straight line, if they're carrying high momentum, it is very likely they will impact in the early generations in the airways. So it will deposit in the trachea, which we don't want them to. So we need to have the right aerosol properties or aerodynamic properties in order to allow the drug to sort of turn the way and get into the smaller airways and when it goes down to the lung. And also in the upper airways, there's lots of mucus, which may trap the foreign particles, including the drug itself, and that it will clear from the lung. So we don't want to see that. So we have to make sure that the formulation can escape the mucociliary clearance mechanism. And also there are lung macrophages in the lung, which may also remove the foreign particles. So the site of deposition is very important because it will directly affect the clinical outcomes. So when the patient inhales the aerosol, there are 3 different areas that the particles may deposit in. So it is very high chance that the particles actually may deposit at the back of the throat, because when the particles, especially if they're large in size, they carry a high momentum. When they breathe in, they will just sort of get straight and deposit at the throat, and eventually the particles will be swallowed and end up in the stomach rather than get into the lung. So we need to develop a smaller particles that allow them to go deeper down in the airways. So bronchial is actually where we want the drugs to locate, because this is usually the site of action for the treatments of infections or other diseases like asthma. If we want to develop a pulmonary delivery system for drug to get absorbed into systemic circulation, then we want to get the drug into the alveolus region. So when we do formulation, what we try to achieve is to allow the particles have the right size in order to reach the target site within the respiratory tract, and usually the bronchioles or the lower airways. And it has been long understood that particles within the range of 1 to 5 micrometers in terms of aerodynamic diameter can deposit in the lower airways. I'll come back to talk about what is aerodynamic diameter in a minute, but this is the size range that we aim to target our formulation. So there has been a lot of work on developing an inhalable formulation for the treatment of lung infection, especially for pseudomonal infection in patients with cystic fibrosis. There's been lots of work focused on this area, and there has been evidence showing that inhalation of antimicrobial agents can achieve a good therapeutic effect, but without the systemic toxicity. So it can reduce the drug's exposure to the systemic circulation and thereby reduce the risk of side effects. And this is very important for the patient, because if the patient experiences side effects, they may not take the medication. So that could also, if we can reduce the side effects, we can also improve the patient's quality of life. And there has also been studied to compare inhaled aerosol in powder form as to liquid formulation. And it was found that patients actually prefer to use dry powder formulation mainly because it is more convenient to use as compared with nebulization. And it is more likely that patients will stick and adhere to the therapy, and that will also increase the clinical outcome, because after all, we need the patient to use the medication in order to treat the condition. So when we have a look at what inhaled formulation has already been approved in the market for the treatment of lung infections. So this is the list of approved formulation, and majority of these are actually antibiotics for the treatment of pseudomonal infections in cystic fibrosis patient. And also there are some antiviral drug for the treatment of influenza. But we notice that there is no antifungal agents in inhalable form being approved. So we see that there seems to be a gap in the pharmaceutical formulation in the market, that maybe we can sort of develop an antifungal agent that could be suitable for inhalation for patients suffering from pulmonary fungal infection. So then we have a look at what antifungal agents out there are used for the treatment of pulmonary mycosis. And there are amphotericin, the triazole, and also the echinocandin, so which are newer antifungal agents. And most of these formulations are in the IV infusions, and there are also the triazole, which is available as an oral formulation. But we all know that antifungal agents, all of them are quite toxic, especially amphotericin. They're notorious for their very nasty side effects. But even for the triazole, they also have some severe toxicity. So if we give this formulation for systemic delivery for lung infection, we either give it by IV infusion or we give oral tablet, but it will have a high dose and patients will suffer from these side effects. So we're thinking that maybe we can formulate antifungal agents as inhalable form. So we also look at clinical study to see if there's any real benefits for the patients if we develop an inhalable antifungal drug for the treatment of for pulmonary aspergillosis. And there has been clinical study showing that by inhaled voriconazole or amphotericin actually can improve the clinical outcome. So one thing I want to point out is that it is quite common, well, not very common, but it happens in the clinic is when there is no alternative, the clinicians may actually use IV formulation as a nebulization form. So just put the IV formulation in a nebulizer for the patient to breathe in. Although it used clinically, but this is not ideal because the IV formulation are not designed for inhalation. So sometimes the formulation, for example, the pH or the osmolarity or the excipients like the preservatives that may be found in the parenteral formulation may actually cause local irritation to the patient. So what may happen is that the patient may react by coughing quite badly, or it may cause bronchospasm. So we still need to have a proper formulation that is designed for inhalation. So we see there is a gap in research. So we are trying to identify an antifungal agents and develop it as a dry powder formulation. One of them we chose is the voriconazole, mainly because it has less side effects as compared with other drugs. And it is also a primary treatment for invasive pulmonary aspergillosis, but it also proved to be useful as a prophylactic for patients that is immunocompromised. For example, patients after organ transplants, they are on immunosuppressants. They may also be susceptible to pulmonary aspergillosis. So the only thing about voriconazole is that it has a low water solubility, so which makes it a bit harder to formulate. Voriconazole itself is available as parenteral and oral routes, but as I mentioned earlier, these two are both systemic delivery. So we need to have either a high dose in order to get to the lung, or parenteral, which is invasive and also increase the risk of toxicity. So the aim of our project is to formulate voriconazole as a dry powder formulation for inhalation. So there are two particle engineering techniques that we use in the laboratory to prepare dry powder for inhalation. The first one is spray drying, which is quite commonly used in the pharmaceutical industry as well as the food industry. So in principle, you need to atomize the liquid, which could be the drug in solution form or in suspension form. So we spray the liquid so that through the nozzle, so that it's atomized into very fine droplets. And inside the drying chamber, there is a hot stream of gas. So this elevated temperature can cause evaporation of the solvent, and this is how we dry the particles. And because the liquid undergo atomization, usually we can control the particle size range quite good. So these are some images of spray dried particles, and you can notice there are different morphology. So if we manipulate the parameters of spray drying, for example, the temperature that we use, the atomization gas flow rate, or we can change the excipients that we use, we can also change the surface properties of these particles, which can have an impact on how the powder can disperse and to be inhaled by the patient. So the advantage of using spray drying is that it is a very quick method to prepare dry powder, and it is easy to scale up because the industry has used it for a long time to prepare dry powder. But the disadvantage is that it requires the use of high temperature to cause the evaporation of the solvent. So it is not suitable for heat-sensitive molecules or biologics. So another method that we use is called the spray freeze drying. So this is less well-established method. The spray freeze drying has multiple steps. So the first step is still spraying. So we atomize the liquid into fine droplets, but instead of spraying into hot gas, we spray into ultra low temperature. And so we usually spray them in a cryogen like liquid nitrogen so that the particles will be instantaneously frozen. And then we will transfer the frozen droplets into a freeze dryer. So during the freeze drying process, they undergo the sublimation of the solvent. So the frozen solvent will change directly from solid state to gas state without being melted. So during this sublimation process, these ice crystal will sublime it and leaving pores in the particles. So the advantage of spray freeze drying is that it doesn't need to go through the high temperature, which means that it is suitable for heat-sensitive molecules. And also the porous particles is actually desirable for inhalation because these porous particles are very light, they have a low density. So in terms of the aerodynamic size, they could be large in physical size, but because it has a low density, it has a small aerodynamic diameter as well. So it makes the particles easy to handle, because if we have a very small particles, they tends to very cohesive and tends to aggregate and not easy to disperse. So if we have a particle physically large in size, but aerodynamically speaking small in size, it will actually be easy to handle. So the only thing we have to be careful with spray freeze drying is that we have to control the porosity. We don't want to make it too porous, because that will affect it will make the particles very fragile, okay? But if it is too dense, then it loses advantage as being light, okay? So we have to make a balance there. So in our study, we tried to formulate fluoroconazole using spray freeze drying technology, and we used a factorial design approach to optimize our formulation. So our formulation is very simple. It has only two components. One is the drug itself, and the other is mannitol, which is a bulking excipient, which is commonly used in the pharmaceutical formulation already. Because fluoroconazole, I mentioned earlier, they are not very soluble in water, so we need to have an organic solvent to dissolve the drug. So we use terbutyl alcohol, TBA, as a co-solvent. The reason we choose this not only because the drug can dissolve in it, but also because these solvent has a relatively high freezing point at 25 degrees Celsius. So it means that these can sublime without having to bring the temperature to ultra low. So it is easy to sublime the solvent. So there are three different factors that we are particularly interested in. First is the solid concentration. So the solid concentration is the solid content in the liquid for the feed solution. So as I mentioned, this will affect the porosity. The higher the solid concentration means that the higher solid content in the liquid, it will produce denser particles, whereas if we decrease the solid concentration, we tend to produce more porous particles, but these particles may be also more fragile. We are also interested in how the drug content may affect the aerosol performance of the particles. So the higher the reconosal contents also mean the lower amount of excipients that we need. And the third factors we look at is the solvent content. So we want to see how the solvent content may affect the final properties of the formulation. So in this factorial design approach, we use the 3 factors, 2 levels. So each of these 3 factors, we assigned a high level and a low level. Okay, so altogether we formulate 8 formulations, which is the 8 corner points of a cube. So we have each formulation have either a high level or the low level of each of the factor. And in addition to these 8 corner points, we also have the center points, which is the center or the mid levels of each of these factors. So there are altogether 9 different formulations that we prepared. So these are the SEM images of the spade fish dried particles that we prepared. So these are 8 formulations, which is the 8 corner points that I showed in the previous slide, and also the center point. So we produce 3 batches of center point. And I think the major thing that you can notice when you compare the images of these different formulations is that when we have a low solid concentration of 1%, we don't seem to see a proper particles there. So what you see is that these particles are clumping together. I think it's because with a low solid concentration, these particles are very fragile and they collapse. And that's why they're highly aggregating. Whereas if we increase the solid concentration to 4%, they become more robust. And that's why you can see the individual discrete particles there. And the other thing you may notice is that these particles are all porous. So they are not solid dense particles, but they are porous with pores that you can notice under the SEM. And the center points is sort of intermediate between the high and the low levels. So what we're interested in is to see how these particles perform as an aerosol. So there are 2 parameters that we are particularly interested in. The first is the fine particle fraction. So these are the percentage of particles with size smaller than 5 micrometers in aerodynamic diameter, which means that these are the percentage of the particles that can deposit in the lower airways. And the second parameters that we are interested in is the emitter fraction, okay? Because we need to use an inhaler to disperse the powder. So these are the fraction of the powder that can exit the inhaler. Because if we have a poor formulated powders, they may be so aggregating that they are not able to aerosolize and they may not leave the inhaler at all. So emitter fractions can give you an indication of how good the aerosolization is during the inhalation by the patient. So we use an equipment called next generation impactor to characterize the aerosol performance of these particles. And you can consider them as a sieve that can separate the particles according to their aerodynamic diameter. And this is how the NGI looks like. So this is the next impactor. This is the throat that connected to the inhaler. So this is the inhaler inside which we'll have the powder of our formulation. And this is connected to the pump at the back so that we can control the flow rates that we want to use. So in this figure here, to show the aerosol performance of these different formulations. So first, the gray bar is the emitter fraction. So most of these formulations actually emitted from the inhalers quite well, with over 80% of emitter fraction. Means that 80% of the powder can successfully leave the inhaler. And the black bar is the fine particle fraction, which is the percentage of the powder that can deposit in the lower airways. And there is a general trend that you can see is that the higher the drug content, the higher the fine particle fraction. So we did a statistical analysis with this factorial design to see which are the important factors. So as you remember, we have 3 factors that we're investigating. And factor B in our design, which is the voriconazole content, have a positive effect on the fine particle fraction, which means that the higher the voriconazole content, the higher the fine particle fraction, which is good because if we have more drug in the formulation, it actually helps to get the drug into the lower airways. But at the same time, you also notice that the factor B, which is the drug content, has a negative effect on the emitter fraction, which means that the higher the voriconazole content in the formulation, the lower the emitter fraction. But having said that, when we look at the actual emitter fraction percentage, all of these formulations have over 80% of emitter fraction. So we're not too concerned about this, although we know that voriconazole tends to have a negative effect on the emitter fraction, it is still reasonably good. So we identified V8. The V8 is the formulation that show a good aerosol performance. And also if you look at the SEM images, these are the V8 formulation, which you can see the quite robust porous particles there. So we identified V8 is our optimal formulation in this factorial design study. And we have done about distribution assay in mice. So we have 2 groups of treatment. One is through intratracheal administration of the dry powder directly into the lung of the animal, and compare that with IV injections of VFAND, which is the commercial formulation of voriconazole for IV injection. And both of these 2 groups of mice are receiving the same dose of voriconazole, and we measure the drug concentration at different time points in the lung, as well as in other organs like the spleen, the kidney, liver, as well as in the plasma, and compare the concentration between the 2 drugs, to compare the concentration of these drugs in these 2 different groups. And as we expected, if we give the drugs through the intratracheal administration in a dry powder form, you can see there's a much higher drug concentration in the lung as compared with the IV administration. So after 30 minutes, the drug concentration is more than 10 times higher than the IV route, which means that if we want to have the same concentrations by the IV route, we have to increase the dose by 10 times. Not only the intratracheal administration can increase the drug concentration in the lung, it can also lower the concentration in other sites. For example, the spleen, kidney, and liver, there is a lower concentration of the drug as compared with the IV formulation. So we show that the pulmonary delivery can increase drug concentration while reduce systemic exposure as compared with the IV route. Then we move to sort of try to improve the formulation further, because V8 contain only 40% of the drug, but which means that 60% of the dry powder is actually the mannitol, which is the excipient. So we do a second factorial design to further enhance or improve our formulation. And this time we not only look at the voriconazole content, we increase from 40 to 80% of the drug. We also look in other parameters like the atomization flow rate and also the primary drying temperature, and see how these operation parameters may affect the formulation. So again, we have 8 formulation plus the center points. So these are the SEM images of the spade feed powders that we prepare using we use a different nozzle. This time we use a 2-fluid nozzle. The first time we used the ultrasonic nozzle. So I'm not going into details about the different nozzle. What you may notice, these look quite different from the previous batch of formulation. you may notice they're less spherical. If you compare these 8 different formulations, you may notice that the formulation prepared with a lower atomization gas flow rate seems to have a more spherical shape as compared with those prepared with a high atomization gas flow rate. And again, all these particles are porous. And what we're interested is the aerosol performance of these formulations. And this time we compare 3 different types of inhalers. These are all commercially available inhalers. So we just use it as off the shelf and see which inhalers is matched best for our formulation. So these 3 inhalers difference in terms of the intrinsic resistance. Again, we look at the fine particle fraction as well as the emitter fractions. And first things that you notice is the breezhaler, which has the lowest resistance, give the higher fine particle fraction. So it seems that the breezhaler match our formulation better, whereas the handyhaler give the lowest fine particle fraction. So by increasing the resistance of the inhaler, it reduces the fine particle fraction of all our formulation. And the second thing we notice is the emitter fraction. This time, the handyhaler actually gives the highest emitter fraction, whereas the breezhaler sort of a moderate emitter fraction, whereas the mid-resistance inhaler gives the poor emitter fraction. But still, we think that the fine particle fraction is the most important parameters because these affect how much drug can deposit in the lung. So we do an analysis of the factorial design and notice that there are 2 important factors that affect the formulation performance. First is factor C. Factor C is the primary drying temperature. So by increasing the primary drying temperature, it reduces the emitter fraction. And also by increasing the drying temperature, actually can increase the fine particle fraction. So the primary drying temperature is important. And second is the voriconazole content. So this is very similar to our first factorial design approach, that increasing the voriconazole content can further increase the fine particle fraction. But this time the voriconazole is not having any effect on the emitter fraction. And because we think the breezhaler, which gives the highest fine particle fraction, we determine that this is a better inhaler for our formulation. So the second thing we do is we also try to use, understand how the flow rate may affect the performance of our formulation, because it is impossible that we tell the patient how hard they breathe in or what flow rate they need to achieve when they inhale the medication. Okay, we can't tell the patient that you need to inhale 90 liters per minute in order to get the drug deposit in the lung. Not only that, each patient is different. Even with the same patient, every time when they inhale, there will be a different flow rate. So we have to want to understand how dependent or how flow rate dependent our formulation is. So we use the breezhaler and disperse the powder at different flow rates. So the 90 liters per minute is a high flow rate, and then we also compare with a lower flow rate at 60 liters per minute. And this could be important when patients have infection because they may have a poor lung function, which means that they may only generate a low flow rate. So in this, we can see that the formulation F5 actually can maintain a high fine particle fraction even when we reduce the flow rate, whereas all other formulations, we can see there is a significant reductions in the fine particle fraction when we reduce the flow rate. So we identified our F5 formulation is our optimal formulation in this factorial design study. So this so far that we've got with this project that show that we can formulate voriconazole by space freeze drying to have good aerosol performance. We understand a bit better about the formulation that the voriconazole content can actually increase the fine particle fraction. Also, during the space freeze drying process, the primary drying temperature does play an important role in affecting the aerosol performance of the particles. We've also done the in vivo biodistribution study to demonstrate that by pulmonary delivery, we can achieve a high drug concentration in the lungs while reduce the systemic exposure. So the next step for our work is to, of course, to try to see whether in vivo model, our formulations can reduce or can have inhibit the fungal infections in the animal. So apart from antifungal agents, just briefly talk about how we use this drying platform of drying technologies to develop other inhalable therapeutics. So we have been also using the messenger RNA in our study. So obviously messenger RNAs are very popular molecules these days. It has a potential for use as an inhalable vaccines in our approach. And apart from a vaccine, messenger RNA can be also used for treat other lung disease. One example is cystic fibrosis, which is a genetic disorder. So we can deliver messenger RNA as a dry powder form for the treatment of different disease. So we also look at, other than antifungal drug, we also look at antiviral drugs, which could be used for the treatments of influenza or even COVID-19. And we also make large molecules like antibodies. So we also use spray drying technology to prepare neutralizing antibodies with potential for COVID-19 treatments. And we have quite good data on how these neutralizing antibodies can reduce the viral load in the lung of animals after intratracheal administration. And lastly, one thing that we are interested in is when we talk about infection in the lung, usually it's not only affect the lower airways, especially when we're talking about antiviral or viral infection. Usually infected both the upper airways and the nasal cavity, as well as the lower airways in the lung. So if we want to deliver drug locally to these two sites, we have to use a nasal spray for nasal delivery and inhalation to the lower airways. So we are thinking, how about if we have one single administration that can deliver the drug at the same time to the nasal cavity as well as in the lower airways. So as a proof of concept, we prepare large particles and small particles. So the large particles will allow the particles to retain in the nasal cavity through nasal administration, whereas the small particles can go into the deep lung area. And by controlling the mix ratio between the large particles and small particles, we can actually control the site of deposition within these two regions. Okay, so this is just a proof of concept. Say there may be a possibility that we can use nasal administration to deposit drug both in the nasal cavity and in the lung that can be controlled. But of course, there are other practical issues that we need to consider. For example, how does the particles that escape from the mucus entrapment in the nasal cavity, and how much dose that we can deliver through the nasal route is something that we still have to investigate. But this is something that we are working on as well. So I think this is all I want to share with you today. So a number of people I need to thank, my collaborators in Sydney, Professor Kim Chen, as well as Dr. Philip Kwok. Of course, the funding from this project on the Royal Council is funded by the Health and Medical Research Fund in Hong Kong, and also my team. And the majority of the work that I present today is done by my previous PhD student, Rachel Liu, who is also co-supervised by Philip. So her PhD is entirely on development of antifungal drugs for inhalation. And thank you all for listening. So I'm happy to take questions.
Thank you very much, Jenny, for the interesting talk. So now we have a Q&A session. Are there any questions from the audience?
Philip, can I just ask what might be a silly question?
Hi, Julie. Yeah.
Hi, Philip. I mean, I've been an asthmatic all my life, so I take Ventolin quite a lot. And I know you talked about the pros and cons of Jenny. You talked about the pros and cons of nebulization versus dry powder. So I guess voriconazole is not water soluble, so you wouldn't use a nebulizer. But I guess my question is, if it was water soluble, why is it that drugs that are water soluble are given through a nebulizer and not something like a Ventolin, which, you know, is something that's really easy for a patient to take?
So the Ventolins, you mean the meter dose inhaler, right? So
yeah, so like
inhaler,
the pressurized thing, you know,
yeah.
like
Yeah,
because it's the same principle as, you know, like, you know, a dry powder, you're breathing in and, you know, you're breathing it in and the patient will take it. Yeah.
Yeah, there's a limitation of the dose that you can deliver by the meter dose inhaler, usually just in a microgram. So it is only suitable for very potent drug like the beta agonist that you use, like the salbutamol that you use, because they're very potent and the dose is in microgram. So it is suitable to meter dose inhaler. But if we're talking about antimicrobial agent, usually is in milligram, tens or even 100 milligrams, then the meter dose inhaler is not suitable to deliver high dose drug. So the option is really back to dry powder inhaler or the nebulizers.
Okay, thank you.
Just to add on that, Julie, so there are examples of hydrophobic drugs being delivered by nebulizers.
Okay.
So for example, budesonide, which is a corticosteroid for asthma, it is available as nebules, but obviously it's not a solution because they hardly dissolve in water, but they are suspended in a water-based vehicle. So, and I suppose that for asthma, if you are using corticosteroid, which is a regular kind of dose, even if the drug dissolves slowly over time, that doesn't really matter, because you want to have a baseline coverage for most of your day, right? For your anti-inflammatory effect. So in theory, if you have a fungal infection, it wouldn't be like a 1 day, 2 day kind of treatment. So if voriconazole is slowly dissolving, it should still be okay, as long as the concentration dissolve is maintained within the therapeutic level, obviously. Yeah, but technically it is possible, yeah, to nebulize a hydrophobic drug.
Okay, great.
May I ask a
yeah,
question?
Justin, yeah.
Yeah, thank you for the talk. It was great. I'm interested, thinking for most of our patients who have fungal lung infections have got structural lung disease as one of the predisposing features. And so I'm not sure what we know. I know you haven't done the in vivo studies yet with your antifungals, but from antibiotic studies, what do we know about the way that drugs distribute, particularly in structurally abnormal lungs, like into cavities, for example?
Yeah, this is the problem with the dry powder formulation, because sometimes you cannot have a very uniform distribution of the drug. So if the patient's really sick, or they have a really poor lung function, or because of the structure problem, liquid formulation may be a better choice, because it can ensure uniform distribution better than the dry powder formulation. So there's a pros and cons. So the dry powder, it is portable, it's easy to use. The solid state is more stable, but it has this problem is the distribution may not be as uniform as a liquid formulation.
And sort of related to that, I guess, another kind of major clinical area that you would want to use these, I guess, would be for those very long duration of therapies. So the patients who have fungal balls, for example. Is this something you see likely being useful for those kind of patients? Is it likely to penetrate a fungal ball, I mean?
I can't answer this, but I see that there's a potential for that. When we think about cystic fibrosis, the patient with cystic fibrosis, their pseudomonas infection, and this sort of affects them for quite a long term. And we still have dry powder formulation available for them to use. So based on what have been done for cystic fibrosis, it seems to be positive that it is feasible, but I can't answer you for sure because I haven't really looked into how the penetration of fungal spores of inhaled formulation is.
Mhm.
Yeah.
That's great. Thanks.
Can I ask?
Hi, Dee.
Thanks very much for the talk, Jenny. It's really interesting. So do you foresee a future where you might have some kind of administration of a bunch of different drugs for a single problem, like CF, where you might be administering messenger RNA plus antifungals plus antibiotics to sort of cover a broad spectrum of the disease?
So you mean have a single formulation, but with different type of therapeutics?
Yeah,
inside?
exactly. Yeah.
Yeah, so it's like a combination approach with different drugs in the same formulation. But I think you need to have these therapeutics, if you're putting in the same formulation, they need to have a matched pharmacokinetic profiles because they are inhaled at the same time. So if one has a short half-life, the other have an extended half-life, then it won't work. So I think it back to the properties of the drug itself to see whether you can put them all together.
Right.
And also, I suppose you have to check whether the different ingredients can interact inside the formulation, especially when you have a macromolecule like mRNA with charges on the nucleic acids. Sometimes they can form a complex with another component in your formulation, and that can affect the way they work. So these are things to consider when you put them together into one combo.
Sure.
Yeah.
Thanks.
Philip, is it okay if I ask Jenny one other question?
Oh yeah, sure. Yeah.
I was just wondering, with cryptococcal infection, would it be better to give an intravenous administration of the initiation therapy of amphotericin B or deliver it through the lungs? And if you did deliver it through the lungs, can it still cross the blood-brain barrier and treat the neurological symptoms from the lungs?
Well, well, this is more of clinical questions. I'm not sure that I can answer this, but what I see in the clinical paper for the treatments of pulmonary aspergillosis, usually they don't just use the pulmonary route. Sometimes in combination. So you can have a lower dose of the IV routes, but at the same time you topically administer to ensure that it's enough in the lung. So that can reduce the systemic route that is needed. So it is, I think, acceptable if you have two routes of administration for patients that really need a high dose. So you do both ways. I don't know about whether it crossed the blood-brain barrier for neurological disease. It is very likely that small molecules can be absorbed in the systemic circulation because the lung is quite permeable. So unless the drug is really hydrophilic, they may not be absorbed as good as more hydrophobic drug. But once it gets into systemic circulation, it just like the IV route or the oral route, it depends on the properties of the drug itself, whether it can cross the blood-brain barrier.
Yeah, I guess it would, but I guess it's whether it achieves an effective concentration when administered through the lung. But like you say, you probably give both and tone down the IV route to reduce the side effects. Yeah. Thank you.
Thanks.
Thanks, Julie. Any other questions? No, if not, then let's thank Jenny again for her interesting talk. Justin, any other things that you want to add?
No, just to say thanks a lot, Jenny. That was great. It's really nice and interesting to have you join.
Thanks for inviting me.
Yeah, great. Hopefully we'll get to meet face to face when all these restrictions finally resolve. Okay, all right. So thank you, and thanks everyone who's joined us online. We look forward to the next talk.
Thank you.
Thanks everyone. See you.